First, you have to remember that diabetic neuropathy is usually the first chronic complication to occur, especially if the patient is not controlling his blood sugar very well. This is usually a very common presentation that the patients will complain of, and it gives you a hint of their poor compliance for their medication. And therefore, if you always remember that this diabetic neuropathy is the earliest one to occur, then it will give you hints to give more time to advise your patient. Especially that this neuropathy will lead to a lot of other complications, most commonly diabetic foot. And this will usually lead to immobilization, and therefore it will lead to worsening complication of this diabetic patient. So let's move on. The first and the most common one is peripheral sensory neuropathy, which is distal symmetric sensory loss. The second type is the motor neuropathy, which is foot drop, wrist drop, mononeuropathy, and cranial neuropathy. It can occur as neuropathy in cranial nerve 3, 5, 7, which is most commonly seen. Autonomic neuropathy, which can lead to postural hypotension, resting tachycardia, loss of sweating, gastrointestinal neuropathy, gastroparesis, diabetic diarrhea, urinary bladder autonomy, and impotence. So diabetic neuropathy. It's the involvement of the peripheral autonomic nervous system, most common complication in diabetes. The clinical diabetic neuropathy is categorized by distant syndrome according to the neurological distribution, although it might overlap the syndrome that can occur. The prevalence is function of the disease, the duration, and based upon several large studies, there is approximately 50% of the patients with diabetes will eventually develop neuropathy. In our study, as we said, peripheral neuropathy will occur in Saudi patients around 13.2%, which is less than what we just said, about 50%. But remember, it is a very common complication. And it's usually the first to occur. You can see the median is around 10 years, plus minus 2, compared to the others which were around 12 and 13 years. It has been confirmed in many other studies, and the best part that will lead to and the risk factors of diabetic nephropathy and the risk factors of diabetic neuropathy is, as we just always said, glycemic control, duration of diabetes, damage of the blood vessel, mechanical injury to the nerves, autoimmune factor, genetic susceptibility, and lifestyle. So smoking and diet will be a higher risk factor of this complication. Systemic sensory polyneuropathy. It's the most common diabetic neuropathy. Sensory involvement usually occur in the first, generally bilateral, symmetrical, associated with decreased perception, vibration, and temperature. Paresthesia and dysesthesia may occur usually after a distal lower extremity, like what we always abbreviate stocking glove sensory loss. Pain, when present, it can range from mild discomfort to a severe pain. Complication of this severe polyneuropathy is usually, as we see a lot in our patient, recurrent ulcers, Charcot arthropathy, discoloration and stress fracture, and unfortunately, the end result, it will lead to amputation. The treatment of systemic polyneuropathy is usually, as every other complication, is very good glycemic control. But don't let your patient suffer. Remember that you need to treat this painful complication by tricyclic antidepressant, amitriptyline, or typical creams. Also, anticonvulsants like gabapentin can be used, and always emphasize in the very good foot care to prevent ulcers and further injuries to the foot. The second type of diabetic neuropathy is polyradiculopathy, which can be one of few types. It can be lumbar, which will cause thigh pain. Your patients will complain of bilateral pains in the thighs and can accompanied by weakness, and especially if he is climbing the stairs. Thoracic type is he will complain like a band around his abdomen, and this band will always have pain and will always have numbness in it. Diabetic neuropathic cachexia, which is systematic peripheral neuropathy with affecting both proximal lower limbs and hands and lower trunk. It's associated with profound weakness and weight loss, and painful dyskinesia, which will be associated mainly with depression. The treatment is usually foot care, glycemic control, and pain control. Don't let your patient suffer. Please control his pain very well. Mononeuropathy, it can be a single nerve that is damaged due to compression or ischemia. It can occur in the wrist, and usually the symptoms will be numbness, edema, pain, pricking, or it can be the cranial mononeuropathy. As we said, it can be one of the mononeuropathy of the cranial nerves. The treatment is glycemic control and pain control. Autonomic neuropathy, on the other hand, it can affect the autonomic nervous system, which can affect the genitourinary, cardiovascular, and it can be classified as clinical or subclinical based on the presence of symptoms. It can contribute to the following signs. It can lead to Charcot joint or Charcot foot, aching, pulsating, tightness, cramping of the dry skin. It can lead to sweating abnormalities and weakening of the bone of the foot that can lead to further fractures. The most important part is testing. Direct recording of postprandial filament fibers, and then you will check his nervous sensation in every visit and measurement of his vascular response. The treatment, as most of the neuropathies, is to watch for diabetic care, diabetic care, diabetic foot care, diabetic foot care. Elevate the feet when he is sitting, eliminate the aggressive drugs, reduce edema. You might use some diuretics to decrease the edema, and to screen for peripheral vascular disease and coronary vascular disease, and you might support it with stockings. Genitourinary autonomic neuropathy. We will speak about certain types and the treatment. Number one is bladder dysfunction, and the treatment usually is voluntary urination. Sometimes it might need voluntary catheterization. Retrograde ejaculation is usually treated by antihistamine. Erectile dysfunction, and this is a very important complication. It causes your diabetic patients to go into depression. So please ask about this complication. Ask your patient if he's having erectile dysfunction. Don't let it move on into becoming a very significant complication. Make it a regular checkup in your questionnaire for your patient. If he's having mild erectile dysfunction, then you can help him in prescribing like sildenafil or any of the agents that will help this erectile dysfunction, or refer him to a urologist, because sexual life is a very important issue in any patient, but also in diabetic patient, it's a very life-changing for them. Dyspareunia, and your female patients will complain of that, and you can treat it by leprechant and estrogen creams. Gastrointestinal autonomic neuropathy. If you look at your patients closely, you will find this is a very common complaint. They will complain of the food is not moving on, there is bloating, there is decrease of gastric emptying, and usually if you look at those patients, you will find they have a very poor diabetic control. The signs and symptoms will be gastroparesis resulting in anorexia, nausea, and vomiting, diabetic enteropathy resulting in diarrhea and constipation, and the treatment of this is a very important issue for a lot of our patients. The usually treatment is to prescribe small frequent meals. You can use metoclopramide, erythromycin, or domperidone. In some selected patients, you can have a botulism toxin that is injected into the pylorus that can reduce the sphincter resistance, which will make the gastric emptying much easier.